Good day, everyone. Thank you for joining our webinar today regarding the use of the Swiss DuoClast in your daily practice. We are happy to welcome today our shockwave expert from Germany, Dr. Peter Stiller. Peter, thank you for being with us.
Hello to everybody.
So just to let you know that Dr. Peter Stiller is a specialist in general and sports medicine. He's based in Germany, and he will provide you more details today about the use of a Swiss DuoClast focused and radial shockwave therapy for your daily practice. Before starting this webinar, I would like also to introduce myself. My name is Mary-Christine Colette. I'm an education specialist working at EMS Electromedical Systems, the Swiss company who created in the early 2000s the Swiss DuoClast method, the use of the radial shockwave therapy. So it's been successfully used worldwide by many practitioners and helped many patients worldwide to regain daily activities in sports and in their daily life. So the Swiss DuoClast method has been extended also to the Swiss DuoClast, but also to the GDT, guided DuoClast therapy. And we'll be discussing today about the use of the Swiss DuoClast. Just a few technical points before starting. As you can see on your screen, you have at the bottom or at the top of your screen, you have a Q&A and chat icons. Please feel free to use them to put your questions, and we'll be able to answer them during the course of this webinar or at the end if it concerns more general questions. So thank you again for your participation. And now we will start. So Peter, the mic is yours.
Okay, thank you very much. Hello to everybody. I think in South Korea it's the starting of the evening. So good evening to all participants in this webinar. It's a pleasure for me to be your speaker tonight, and a real honor that so many shockwave interested people have signed up. We start, of course, with this. Marie-Christine was so nice to introduce myself, so I don't have to do that anymore. And we start with the theory today, which means that the content of the whole webinar is, on the one side, the evidence-based medicine that is behind it. So we will have a little part of science to talk about. Then, of course, the technology that stands behind ESWT and RSWT, means the DuoClast, the molecular and cellular mechanisms, of course, the indications, which are, I'm sure, for you different than the indications that you heard before, because we did a lot of off-label use the last years to get more indications in use than the treatment of first-time diagnosed tendinopathies, because this is, I think, the basis of all. And contraindications we'll have to discuss, because I mentioned it, off-label use is very common at the moment with this great device. So, but first of all, we have to talk about one man who is my mentor concerning shockwave therapy. All scientific data that we will see today in this webinar is proven by him. He's one of the, in my eyes, one of the world's leading shockwave scientists, one of the three best that you can have. And Professor Christoph Schmitz, he's head of the Department of Neuroanatomy at the University of Munich, and member of the Clinical Science and Research Committee. He was working for EMS until 2017 and did a lot of studies. We'll only see a little bit of it, the part you have to know about if you want to work with the DuoClast. Only just for a second that you see that in Germany, our network is very big and it's of high quality. This is the network I'm working together nearly every day or every week in chats and discussing indications and how to treat people with different and really difficult indications. You see on this page about 12, I think 12, yeah, 12 team doctors of professional sports leagues in Germany and about 5 physiotherapists working with professional sportsmen every day. So it is really of high quality, and there's a lot of experience in this network, and you can use this when you hear this webinar. What do we want to achieve for you with the DuoClast? First of all, of course, no or less medication, no injections, especially no cortisone, because if you work with the DuoClast, you can really bring cortisone out of your business. I think I will tell you why today. You have no or fewer operations. It is non-invasive, less risk when you're treating, and this high effectiveness is proven in studies all over the world. And so let's start with this proven studies. We talk about the PEDRO database. PEDRO means Physiotherapy Evidence Database, where you can see there are 48,000 RCTs and systemic reviews in it. So it is a big database we are talking about, and we are using the information from. It is located in Sydney at the George Institute for Global Health at the University of Sydney. And it is about only conservative, means non-invasive orthopedics. Physiotherapy is different to the physiotherapy we have in Germany. Physiotherapy is completely not orthopedic in Germany, because orthopedic, conservative or surgical is only for doctors. In the countries like Australia, Norway, Netherlands, and so on, it is different because they have a wider and broader education. So it is not, or it is a big, how do you say, a big database that we use with the whole orthopedic, you can say. It's only that we have no information about surgical things, but this is not what we want to discuss, because we can't do surgery with the DuoClast, not yet. Okay, just to show you a little bit in half a minute that the PEDRO scale is very reliable and very valid. There are 4 studies only to show how valid and how reliable it is compared to other scales, and it's better than most of them. And it always depends on the Delphi list, which is very important, because Delphi list says what do studies have to do to get into such a database, and there are really high, it's a high scale, so not everybody can come into this database with this study. Studies about shockwave started in the PEDRO database 1996. They were all focused, of course, because focus was the first shockwave therapy theme that they discussed. And then after 2003, it started with the radial shockwave, which is technically completely different. So we see here the red ones focused and the blue ones radial. And you see at the end, and it's going on like this, the radial shockwave studies are increasing more and more because we, of course, as I said at the beginning, we have more indications now, and the indications are growing mostly on the radial shockwave side, not on the focused. And so that's why blue is going up and red is going down and down. I don't want to bore you, but I have to show you a few studies and give you an overview over the most important studies. What I want to tell you is that you can see on this slide that there is nearly only data from the Swiss DuoClast. That doesn't mean that only the DuoClast was used because EMS was so busy and so working more than others, but the results were so good that they could come into the PEDRO database because they used the DuoClast. And that's why 75% of the studies were made with the DuoClast. Of course, there are also negative outcomes. I want to show you the subacromial pain syndrome of Mrs. Engebretsen from Norway. I want to explain why this is has a negative outcome, because in Norway, the subacromial pain syndrome includes the whole rotator cuff rupture, the complete rupture, and that we cannot heal the complete rupture by using the DuoClast. I think this is very obvious for everybody. So this study couldn't get a positive outcome. We knew that before, but they did the whole study with this negative outcome that we could pretend before. Another one is the plantar tendinopathy. The third one in this scale here, Mr. Rompe and his team. This has a negative outcome, but I want to tell you about this exactly at the end of the webinar, because it's a little bit funny. And so we have a funny thing at the end. Okay, important conclusions. The years before, I had more than about 10 conclusions. I shortened it to 3 because these 3 conclusions are really interesting, and those 3 you have to, I think you have to stay in your mind. There are no general advantages for the focused shockwave therapy over the radial shockwave therapy. It's always said, if you have a look into the internet about shockwave, it always says, oh, high energy and the best one is focused, and the low energy and not so good is radial shockwave. That is absolutely nonsense, and it's an outdated opinion, I would say, and I will show you why this is not the case. And 75%, as I said before, of these RCTs here are made by the device we use. For me, the best on the market, but I will show you why it is the best on the market. The technology behind it is easy to explain because we have 2 ways. The one is focused. Focused means that it is not really mechanical. I would say the radial is the mechanical one. The focused is created another way, and it started with the lithotripsy, means to crack kidney stones. They used the shock waves years and years before, decades before, and from this technique they invented the focused shockwave for musculoskeletal system. And after that, and that's why we have the studies from 1996 with focused, and later with radial, they invented the radial shockwave to apply on the musculoskeletal system later. If you see, I go back once, you see it's RESWT. On this slide, it's RSWT. We have to explain it's exactly the same, but RSWT is only a registered trademark of EMS. So if you see RSWT, it's only the DuoClast is concerned. Okay. What are shock waves? Shock waves are single acoustic pulses. You can see these pulses here on the pictures. For example, this warship firing his cannons. There you can see that the first pulse is a little bit big on the water. When a jet strikes through the sound barrier, it's the same. Or if you see a lightning, then you have a very short and hard single acoustic pulses. And these pulses are used, as you see here, in a very short time to create a shock wave. It is sometimes higher than 100 megapascal. So we're talking about 500 bar. It's really a hard pressure. In a time that is very, very short, means in about 10 nanoseconds. The positive pressure is always followed by a negative pressure, about -10 megapascal. But the lifetime of the whole wave is very short. This is a big difference because this is the physical definition of a real shock wave. This is a big difference, as you can see on the next diagram, to the therapeutic shock waves or pressure waves, but I will explain the difference now. Here you see the diagram of a real physical shock wave. So you see 100 megapascal, you see a very short time to rise up, and then a very short time for the whole wave. if you see the modern definition here of therapeutic shock waves, means pressure waves. You have a maximum pressure from about 10 to 100 megapascal, which is a big difference. A rising time about 1 microsecond. So this is about 100 times longer than the physical definition. And you have about -1 to -10 megapascal on the negative side, and it is a much longer time for the wave. If we talk about therapeutic shock waves, so you will ask yourself, so what do we do with therapeutic shock waves if they are not real shock waves? Professor Schmitz and Mr. Rompe and John Furia, I think these are the 3 biggest scientists on the on shockwaves that we have in the world, did a study on what do we need to have a result in the tissue. Do we need real shock waves, which would have been not very good and not very comfortable for the patient, because this really hurts if you always have to create real shock waves. But the pressure waves we get are strong enough to be used in the musculoskeletal system to have great results. And here the study said it doesn't depend on the physical divination. To show that, we have another study on the stored stool lid. It's another device on the market. It's comparable to the DuoClast of Swiss DuoClast of EMS. The peak positive pressure of this device is between 2 and 45 megapascal. So you see it's less, much less than the DuoClast. So I'll show you in the next file how much less. And the negative pressure goes from -2 to -11 megapascal. The pulse rise is very slow if you compare it to the physical definition. And they say after the study, in no setting, this machine, this device can form real shock waves as it is in the definition of the physics. And the true shock wave could be obtained in water if the initial pressure output of the device were doubled. This is very important and very interesting, because if you see the next file now, here you see in the table, you see 42.7 megapascal is the highest, the peak pressure that this stored stool lid can achieve. And concerning the EMS DuoClast, it is 82.2. So it is exactly double. It's the same with the energy flux density. It's 0.23 millijoule per square millimeters, and it's 0.4 with the EMS DuoClast. So you see it is the pressure is doubled and the energy is doubled, and that's why in the highest setting the EMS DuoClast reaches a peak that really generates real shock waves, as you had at the physical definition. How does radial shock wave work? It's a ballistic generation, means that compressed air coming up from down there where you see it in the picture accelerates a projectile to up to 90 kilometers per hour. They strike to a fixed applicator at the front, and from the applicator surface you get the shock waves coming out in a radial way. That's why it's called radial. A second, we can show you this. Yeah, exactly. We can show you this in a video. You see do it again. You see the front of the first shock waves, then you get second shock waves, and these black bubbles is not pepper, but cavitation bubbles. And these cavitation bubbles are very, very important. A few files later, you will see why. This is a picture where you can see perfectly the cavitation bubbles, the secondary shock waves, and the wavefront where we have the first shock waves. And if you compare several devices, the most important thing and very easy to understand is that the radial shock waves generated by a DuoClast are holding the pressure and the energy much longer if you go up with the frequency. So that's why nearly all guys working our network are only working with 20 hertz because you don't have to slower your device, because if you see it from the 4-bar line, if you work with 1 bar or with 4 bar, it doesn't matter. You can keep your energy and your pressure nearly completely the same with 1 hertz and 20 hertz. But we want to work fast and we want to work with less pain for the patient. And if you tried it on yourself with 1 hertz or 5 hertz, and then you put it up to 20 hertz, you will see that the pain is much more when you have less frequency, less hertz. And that's why we work with 20 hertz. And if you see the competitor on the market, this is really, really unbelievable, but it is the case. They have 5-bar or 6-bar devices, but if you see how the line goes down after about 5 hertz, 10 hertz, and then on 15 hertz, you get the same pressure and the same energy after when you use 15 hertz the devices with 1 bar, the EMS DuoClast, and 5 bar from the competitors. They are all the same. So there's no question which one is at the moment the best on the market, and for you exactly the best to use for the best results. To the focused ESWT, the piezoelectric generation, I explain you this one because this is the DuoClast from EMS. There are 2 more ways to generate focused shockwaves. I'll tell you afterwards. This one works like a bowl where the piezoceramic crystals are arranged in. You have thousands of these piezoceramic crystals, and if you put a high voltage of about, I think it's 11,000 volts on these crystals, there are 1,000 little pressure waves coming together, and they are focused from the elliptic form. They are focused in the middle after 5 centimeters to get the right depth into the tissue. You have like pillows that you put on the front with 1, 2, 3, 4 centimeters, so you can exactly arrange where you want to hit the focus of the indication you treat. Wait a second. This is how I said the 3 kinds of generating focused shock waves. The electrohydraulic way, there's a high energy electric impulse that makes heat at the end of this probe in there, and then underwater gas bubbles implode, and so there's a lot of energy which is focused through the elliptic form as the same way as the piezoelectric one. And the second is the electromagnetic way of generating focused shock waves. You have high voltage on a chain of magnets and a membrane in the front of it, the membrane swinging, and an acoustic lens brings it together to the focus point. To show you the piezoelectric from the EMS DuoClast, it works like this. The waves come up as at the radial, but they are immediately turned to the middle, and then you can see a lot of cavitation bubbles, which is very important. Show you once again, because I think this is really impressive. I have to go back. It doesn't work like this. Yeah, no. And then you see after about 5 centimeters, without one of these gel pillows, it's 5 centimeters, the focus comes in. Okay, this is a photo of it, so you can see the shockwave focus in the middle, the cavitation bubbles coming up, and the secondary shock waves that we also need. And this is the highest energy level that you can have, the highest pressure level, I would say. It's the intensity 20 on this device. Then you have the biggest focus, of course. It's 5 centimeters in its length and 2 centimeters wide. If you have less than 20, intensity 20, and I had only 3 patients of 20, 30,000 who could manage to hold on in the intensity of 20, it is really hard. Then the focus is getting smaller and smaller if you have intensity of 10 or 5. Okay. To show you that when you work with less energy than the highest reachable setting, the megapascals that come up from a radial device at I think this is 2 bar. Yeah, with 2 bar, there you have 5 megapascal positive pressure, but always -10 negative pressure, which means a lot of cavitation, even with only 2 bar. And here is the intensity 10, means the half of the power that the DuoClast has. And there you see you have 30 megapascal in the peak with intensity 10 and -10 with half of the power that the device has. I wanted to show you, this is only conclusion for you. You have the picture and it says what physical characteristics of the Swiss DuoClast and Swiss DuoClast we have when they generate shock waves. But what I want to show you is this. At the beginning, I said everybody normally says focused shock waves are stronger, it's higher energy and so on. That's not correct, because if you see the DuoClast here, we have the highest energy flux density, it's called, from 0.4 millijoule per square millimeter, as I said before. And if you take the handpiece Power Plus, we often use it for pseudoarthrosis. For the DuoClast, you can see that the highest peak is at 0.55 millijoule per square millimeter. It's much more than the focus device. So this is to prove that it's nonsense to tell you that focused is high energy and radial is low energy. Here there is a study to prove that cavitation is very important for the tissue, for the effect in the tissue for healing. Big study. And now you can see how that works. In the negative pressure phase, you have the cavitation coming up, and then these cavitation bubbles implode when they are hit by the secondary shock waves, and then a jet stream occurs, which is much more energy than only the first wave front. To show you the difference between the devices, these are photos of the cavitation bubbles coming up. There are some competitors on the market which have no cavitation. We don't talk about them. Here's one from Storz and BTL. And these are the two we are talking about from EMS. This is the Evo Blue. This is an older one. You don't have to look at this. This is the EMS Evo Blue handpiece. And this is the, as I said before, the Power Plus handpiece. And now have a look. If you look at 4 bar 1 hertz, you see that with 1 hertz, the bubbles coming up are nearly the same with every handpiece. With 4 bar and 15 hertz, you have a lot of bubbles with the EMS E and EMS P. And now compare this to the 5 bar 15 hertz of BTL and Storz, and you see that even when there are only 4 bar reachable with the EMS and 5 bar with the competitors, the bubbles are much less. I'll show you in the next and in the next file. Now you can see it here, I think, but you can see it better here. This is a picture, a diagram from the computer, because the computer counts the bubbles. And then you can see that EMS E and P is much more with 4 bar and 15 hertz than BTL and Storz. And this is the big difference. If you want to see that in a video, look at this. I hope. Yeah, now it works. This is a comparison of Storz with 5 bar and 11 hertz. It's only 11 hertz, so that the difference shouldn't be so big. And EMS 4 bar, 11 hertz. The dark blue one is the Storz device. Now you see the bubbles coming up. And this is not because one is still water and the other is sparkling water. The water is the same in both glasses. And we can see the same. We start the second video. We can see the same with a device from, I think it's BTL, with 6 bar and 11 hertz to 4 bar and 11 hertz with the EMS DuoClast. It is exactly the same. If you see that, I think the videos speak for themselves. I don't have to tell you anything about it. You can see what happens. Comparison of the Swiss DuoClast to end this theme and the duolid at the highest settings is that the DuoClast is about 110 to 115 megapascal and minus 20 megapascal, which is a big difference to the reachable 42, 45 megapascal of the duolid and minus 10 in the negative phase. So we can leave the technical things and now go to the molecular and cellular mechanisms of action of the shock waves. This is a slide for everybody as a kind of conclusion so that you can show it to your patients, because everything is a little bit on this. We will go through every point now. What is the effect of shockwave therapy? First of all, pain relief or pain elimination, if it works the best way. The second is the increase of the blood circulation. And for me, the most important things is the inhibition of inflammation and the activation of reparative processes in the tissue you want to treat. And the muscle relaxing effect is very good. But it's not, for me, the most important are these two for the healing process, 3 and 4. To explain all these things, we have to have a short look on the model for tendinopathies, how they are created, I would say, because in most of the cases, it's patient skilled because he did a excessive overload or a long time overload that is not so high, but it's too much for the tendon, and he doesn't react on it, because we get a reactive tendinopathy with a short and hard overload or a little overload for a long time, and then we have to react and say, okay, now we need a rest, but nobody does the rest that he needs, and so it goes on to a tendon disrepair, and then it goes on to a degenerative tendinopathy stage, which is a stage that is not reversible at all in most of the times. But if we work or react earlier, we have a full reversibility in this stage, and we also work on the degenerative tendinopathies because we get more life quality and less pain for the patient. But it may be that we don't reach a real healing. Now we have to compare acute tendinitis and chronic tendinopathy, because acute tendinitis means that the pain is rising very fast, the inflammation is rising very fast, it's extremely painful in the first hours, and the people are running to the doctor very fast. If somebody's coming to you with an acute tendinitis, you cannot work with the DuoClast because shockwave is in most of the cases too painful for the patient. That's the time for RICE, putting some rest and ice on it, and wait for time to get the pain away, and then treat the patient afterwards. We'll have in the next webinars that we'll have some examples for using ice and laser and so on before we use the shockwave therapy. If the patient comes with a chronic tendinopathy, means there was a big pain at the beginning, he didn't go to the doctor, then it went better by its own, and then comes again, like you see here in the diagram, and reaches a pain level that he cannot stand. Then they come, but this is where we can start immediately with shock waves, and that's what we want to do and show you. But first of all, I have to explain why this is the way how these chronic tendinopathies occur or be generated. You have an injured tissue, means the overload, and then the neuropeptide substance P, as you can see here on the picture, is released, which causes the mast cells to put out histamine and have an inflammatory reaction. This leads, and the working on the blood vessels of substance P leads to edema, hyperemia, and erythema, which everybody can see. This is because it is of peripheral sensory neurons. It's the neurogenic inflammation. I think everybody of you knows this neurogenic inflammation from Dr. Müller-Wohlfahrt from Germany. He's the former team doctor of Bayern Munich. This was his biggest invention, I would say, that he told everybody, if you don't work with the against the neurogenic inflammation and only local, then you have no chance to heal the patient. And I think he is right until today. There's nothing to say and nothing to say against it. Now, how can we work against the substance P, against the effect of substance P? If you see the shockwave, for example, shockwave in the internet and so on, you always see, or not always, but in most of the cases, you see a chili pepper. This is not only because chili peppers look nice, this is because of the capsaicin that is contained in red chili peppers. This from, if you bite on a chili, it hurts you. It is hot and it's a pain on the tongue. And if you do that 3 or 4 or 5 times, it's getting less and less and less painful. And that's why, this is the so-called C nerves that you saw in the picture here, the C nerve fiber. They are responsible for transmitting pain. And if you put the capsaicin on the tongue, substance P is coming out, and the depots are depleted after you put it 3 or 4 or 5 times on it. And I call it, first it burns, then it goes numb. This is nearly the same with the shockwave therapy, because shockwaves do the same in the tissue as capsaicin does on the tongue if you bite on it. And then substance P first leads to a pain, that's pain first, and then recovery. That means that with prolonged activation, the C nerve fibers become incapable for some time of releasing substance P, and so the pain goes down. And if the pain goes down, also the neurogenic inflammation goes down. Less substance P is less pain and less neurogenic inflammation. And the decrease of the neurogenic inflammation plus the release of growth factors, which is proven in the study down here. I won't talk about all these studies now because I think this is boring to you only to talk about studies, but they are very important because they prove that the release of growth factors is an effect of the shockwave that occurs in nearly every tissue, and the activation of stem cells into the treated tissue is also proven through the studies, from the studies down there. And if this comes together, the decrease of neurogenic inflammation and the release of growth factors and the activation of stem cells, we get healing. And that's what we want. We want regenerative medicine, means healing in the tissue and not only make it numb for a few minutes. And here, one more study that is important. The cavitation bubbles are especially working on the nervous system too. The effect of shock waves on the nervous system is directly depending on the cavitation that the device can create. Now, at this point, I always read these lines because I think it's a very good summary for you. The prolonged activation of pain and heat sensing neurons, unmyelinated C fibers, by capsaicin or shock waves depletes presynaptic substance P, one of the body's neurotransmitters for pain and heat. The result appears to be that capsaicin mimics a burning sensation and pain. The nerves are overwhelmed by the influx and are unable to report pain for an extended period of time. With chronic exposure to capsaicin, or as we said, repetitive shock wave, neurons are depleted of neurotransmitters, and it leads to reduction in sensation of pain and blockade of neurogenic inflammation, which is for me the most important thing. If capsaicin is removed or shock waves, the neurons recover, which is very important and the big difference to the local anesthesia if you do an injection. Talking about local anesthesia, please never put shock waves on tissue that was injected with local anesthesia. You don't need local anesthesia if you work with shock waves. The effect is reduced immediately, and so the effect will be nearly over in the moment you put local anesthesia in it. I know that a lot of people say you always have to work with the highest pressure, with 4 bar or more. But I would say if you work with the DuoClast, the DuoClast and the PiezoClast, you have so much energy working in the tissue. You can go down with the pressure depending on the pain of the patient. It's really, really important. Work with your patient, talk to your patient, work with the pain as a good pain, not a bad pain. So if the patient runs away, it's been too much. If the patient says, okay, that's okay, I can stand this, then work on. And if the pain gets better, you can increase a little bit the pressure, but never put the pain on the patient that he wants to run away. And if you have the people saying you always have to put 4 bar, 5 bar, 6 bar on it, and if it doesn't work, put local anesthesia in it. Tell them this is nonsense, and please don't do that. Okay. It doesn't work. How does shockwave therapy work? It increases, it's just a summary, it increases the release of numerous messenger substances, for example, substance P, which is the most important, and it causes analgesia and increased blood flow. Then we have the gate control principle. This is an overstimulation of the A delta nerve fibers, the faster ones, and they work back on the C fibers, but only a little bit. Is not comparable with the effect on the C fibers, but it is also working for our effect that we want to reach. The activation of cellular defense and own repair mechanism is very, very important. For example, the sprouting of local nerve receptors, angiogenesis, stimulating fibroblasts, osteoblasts, and so on. All the cells in the tissue are stimulated. The inhibition of COX-2, which is the same as if you work with ibuprofen or diclofenac or anything like this, but this is a local effect, and you have no side effects. And the vibration of the tissue, maybe that this is the case that it works for the muscle relaxation that we sometimes use. What does it do in the tissue? As I said before, the reduction of the chronic pain, the blockade of the neurogenic inflammation, the activation of stem cells, very, very, very important, the release of growth factors, and improves the blood circulation in the treated tissue. So now with this summary, you know how it works. And now I think everybody can think by its own what the indications are. But over the last years, we had a lot of new indications. These are the typical ones, and also the ones that you can treat with radial and focused shockwave. We will discuss afterwards, I think, where it is better to work with the radial shockwave and the focused shockwave, or put it together. I, for myself, prefer working with both in some cases. I need the radial more than the focused, but if I need the focused, I try to combine it, because I think then it is much more energy that you get in and a better effect. The typical indications are, for example, the calcified shoulder, as you know, tendinopathies in the shoulder. The achillodynia means the tendinopathy at the end of the Achilles tendon. The entesiopathia at the elbow means the tennis elbow and golf elbow. The entesiopathia at the patella tendon, very, very important. And of course, the heel spur, the plantar fasciopathy. These are the 5 classic indications that all of you heard before, I think. These are the approved new, means other indications for the Swiss DuoClast, for example, and we'll talk about it. The trigger points, lymphedema, very, very important. Then the, where is it? The pseudoauricular radicular lower back pain, very important. The wound management, even in diabetes feet, and the medial tibial stress syndrome, for example, very, very important, because we have it in a lot of cases with sportsmen. The modern means additional indications that are partially off-label, but we use them nearly every day. We have to talk to the patients before and tell them about the contraindications and tell them that this is partly off-label. But then if you explain it to the people, most of them really work very good together with you and understand why it can work and bring them more life quality and less pain. And these are the indications. We work on all forms of muscle injuries, from hardening muscles, myogenosis, to a real rupture in the muscle, the osteoarthritis in nearly every, or I mean every joint, for example, and very important in the fingers. That's why we wrote here chronic polyarthritis in the hands. This is really, really impressive to see people coming in, not able to move their hands, not able to hold up light things. And then they go out and the fingers go like this and they can shake the hand with power. Then all kinds of spine syndrome means cervical, lumbar, and where it's missing. Okay, it doesn't matter. All kinds of spine syndrome, from the cervical one down to the lumbar and the sacroiliitis. Then fractures, pseudoarthrosis, bone bruises, all kinds of bone bruises, osteochondrosis dissecans we are working on, tension headache, even migraine, because migraines in most of the cases comes from tension headaches, lymphedema, Tractus syndrome, the morbus Schlatter means the the tendinopathy of the patella tendon in young people. Morbus Sever means the same with calcaneus. And the new one that I was forced to use for my own daughter, it was 14 years, is that we tried it with corona. My daughter was suffering from corona and had a real bad lung for about 9 or 10 days. All the medications that you can give had no and absolutely no effect. And then I got the new device from EMS, the new DuoClast that is portable, and we worked on her lung 5 days every day. And after these 5 days, she could breathe 95% normally. We used it in more cases now, and the result was always the same. Even if with long COVID syndrome, we have the same results at the moment. It's only single cases, in 10 or 12 at the moment, but all with the same result. And we'll see what comes up in the future. To show you how important the DuoClast can be for the professional football players, for example, this is a study from 2017 and 18 from the first Bundesliga, the first league in Germany football. There we have these indications, and these indications together make about 79% of all injury days of all players. And these are exactly the indications that you can treat by shockwave and can be treated much faster to get the player back on the field and completely recovered than with physiotherapy on its own, for example, or injections. Now we have a comparison between radial shockwave and the way Dr. Müller-Wohlfahrt, as I said before, the team doctor of Bayern Munich, works with muscle injuries. He always injects ectovagin and Tromel. Ectovagin is from, I think it's a blood it's from, what do you call it? Sorry, don't have the word for it. It's
is it anticoagulant you are looking for?
No, it's no. You get it from the blood. It's I think it's best explained with growth factors that are in the blood, but it's from animals. I'm not quite sure. It's I don't know, but it's growth factors from blood that you are allowed to use in the muscle, and Tromel is homeopathic against inflammation, and they put it together because here's a study from Mr. Smits and Professor Matiasowski. You saw him on the file at the beginning. He's one of our networkers, and they proved that, they've proven that shockwave work perfectly on the muscles in case of injury. And here's a study that shows that the combination of ectovagin and Tromel works works also very good on muscle injuries. But if you see the pictures, another comparison study, you can see that ectovagin itself doesn't work on the muscle. Tromel itself doesn't work on the muscle, but the combination works on the muscle. And it was the best thing we had before the study of the shockwave. And now in this study, you can prove that the radial shockwave therapy was better for the muscle and the recovery of the muscle and the healing of the muscle than the best treatment that Dr. Müller-Wohlfahrt had. If you compare it with diclofenac, it's even worse. So the best one is radial shockwave on its own. Here's the comparison. That's why we have a new study coming up with Mr. Kropnik from Argentina. There's only acute hamstring muscle ruptures. It's a type 3B from Dr. Müller-Wohlfahrt, and we compared shockwave with physiotherapy, intensive physiotherapy, and the results are coming up next year, I think. Now, how I think a very important point that can be worked with a shockwave on it are the trigger points. If you see this picture, I was allowed to use it because this is also Professor Matiasowski. After a symposium we had in Germany, we were flying back from the north of Germany, flying back to the south, and he was sitting in the airport like this. And then we said, okay, this is bad for nearly every trigger point that we know. And that's why, because people in the whole world are sitting like this and suffering from the same problems with their muscles because of the trigger points. Then we said, okay, put this photo in it and then show the people how shockwaves can work. First of all, the pathophysiology of trigger points is that we knew before only that muscle overload leads to these musculoskeletal dysfunctions, but we didn't understand how it works and why it is so hard to treat. Then we had Mr. Simmons and Travell working very, very detailed on trigger points and taut bands so that they could explain how these trigger points work. And they said, okay, if you get more fiber tension, you get a taut band. This means it leads to a local hypoxia. The tissue gets into distress with less ATP. This sensitizes to more pain, so that the automatic modulation gets more fiber tension and so on. And this is always working in a circle. And after that, the biochemical researches on trigger points brought an impressive result, I think. It says that the biochemical milieu of selected inflammatory mediators, neuropeptides and cytokines, were nearly the same as in the tendinopathies. And this is very important because we are working on tendinopathies with the shockwave therapy for years and years with very good results. And now we see that in these trigger points, we have nearly the same milieu, so we can work on them exactly the same way and get very, very good results, because we are not only doing acupuncture or acupressure on it, like a lot of physiotherapists do to get the muscle less hard, but we work on the real problem that is in the tissue, means the inflammatory problem. And so we get much better results if we work with shock waves and physiotherapy compared with physiotherapy on its own. Yeah, the conclusion is, of course, that these trigger points are caused by the overuse of muscles, can be acute or chronic. The biochemical milieu is, as I said, nearly the same as in tendinopathies, and that's why shockwaves work so perfectly on trigger points. Now some files with single points that are very important. You all know that tendon gliding is very, you need a lubricant for the tendon gliding. It is called lubricin, is found exactly where the most, where there could be a scratch between the muscle and the muscle skin. This is why lubricin, the lubricant that the body builds, has to be there to guarantee a better gliding. There are only two ways of bringing lubricin up. The first is moving. The movement makes it makes the body produce lubricin, and the second one is shockwave. So we work on people that have a plaster after operation and are not allowed to move the extremity. So we put the shockwave on it to get more lubricin and get a better tendon gliding. They're getting they heal much better, and they're after the time of the plaster, they can go out and walk properly or move properly, because there is still lubricin in it and it's not so dry. And now here's the study that proves that shockwaves increase the lubricin expression. Then radial shockwave improves blood supply. This is for wound healing, for example. This is absolutely well known over the whole world. I think that wound healing is much better with shock waves. Then some words about the bone, the effect on the bone. A lot of people, if you talk about shock waves, say, "Oh, that's very difficult because you have to be there are actions because of the problem that it breaks the bone." This is absolutely nonsense, really absolutely nonsense. If you see shock waves have in the highest settings, a peak of energy of 0.5, 0.4 millijoule per square millimeters, as I said before, to get a crack into the hard part of the bone. You have to have 1.2 millijoule to square millimeters. Sorry, this is really a big difference. So this is 200% more. You cannot reach nearly 200% more. You cannot reach such a high energy flux density in the tissue that you break the bone. This is nonsense, and most of the people run away if you only get 0.5 or 0.4 energy millijoule. So this is, you cannot break the bone. This is very, very important. This was the first study that showed that you can heal the bone with low energy, means with radial. Low energy is still that low energy, but it's not correct, but it's meant for radial shockwave. And it can be used in osteoporosis, for example. Here it is proven with this study that the osteoblasts are stimulated and the proliferation is stimulated. These are the conclusions concerning pseudoarthrosis. I only want to show you a few of them. The efficiency and safety of shockwave treatment for non-humans was demonstrated repeatedly in the scientific literature. This is really important. And you can see that both the Swiss DuoClast and the Swiss PiezoClast can apply in the treatment of non-unions. This is not very important. This is very important. One way how it works is that the shock waves in the softer part of the bone force the micro cracks that we had before when the break of the bone happened. We have a lot of micro cracks in the softer tissue. The micro cracks are important because from them the osteoblasts are sent out to heal the bone. If you keep the micro cracks a little bit longer, there's more and more the micro cracks lead to more and more osteoblasts when they stand longer, and that's what shock waves do. They don't make new micro cracks, but they hold them, I would say, a little bit longer open like a door, so that osteoblasts can go out and work on the muscle, on the bone. Sorry. Yeah, here you see it on the number 8 exactly, and here at the end, that's why I put it in red. It is proven that even with very low energy flux density with 0.15 millijoule, you can also work successful on the bone. You don't have to have always the highest settings. That's very important because the pain on the broken bone can be very terrible for the patient. So it is not important to do the highest setting and get a lot of pain with the patient. You can go down with the pressure. So the treatment of new diagnosed tendinopathies, this is only to show you how in Germany we have to work. If you have a normal insurance, the plantar fasciopathy is the first indication that you are allowed to treat in Germany with shockwave. If the patient is only a normal ground insurance, if you can see, you have to do this for 6 weeks on the left side, initial tier. The second tier, the second step, is in the middle for the first 6 months, and after these 2 steps you're allowed to get on the third tier and then start shockwave. It is unbelievable that you have to suffer for 6 months. You have to get corticosteroid injections, you have to have x-rays and so on, and only if all these things doesn't work and you are suffering for 6 months, have bad pain, have chronic pain, then it is allowed to do 3 shockwave therapies. This is unbelievable, that a therapy that is so well proven over the whole world is not even for the normal people, I would say, only for people with private insurance or paying from their self. It is, yeah, it's nonsense. But I wanted to show you that even I can tell you whatever I want, that the studies are proven for years and years and decades. But in Germany, it didn't reach the insurance companies. This is how I said at the beginning, the study from Mr. Rompe for the plantar fasciopathy. It is funny because this is in short words what the patients have to do when they're suffering from plantar fasciopathy. This is a program they can do, that kind of training every day for 3 times for 8 weeks. If they do this, which is very it's getting all your time away, because it needs about 15 minutes 3 times a day for 8 weeks. And after that, they compare this program to a 3-time treatment by shockwave 3 times in a row in 3 weeks. And after 8 weeks and 12 weeks, they compared it. After 8 weeks, the result was a little bit better on the training side, of course. I mean, 8 weeks training and 3 little shockwaves, that was clear. After 6 months, the results get positive. Means the shockwave works better after 6 months and 12 months than this program for 8 weeks. But the study was only meant for the 8 weeks, and that's why the outcome is negative. So sometimes you have to look behind the study to understand why it is with a negative outcome. Okay, this is very important because we come back to cortisone injections. This is a comparison of shockwave against cortisone injections at the tennis elbow. We have 2 different scores, pain scores here at the side, this one and this one, the 100-point score. But the diagrams are exactly the same. If you see, the shockwave group is in gray and the steroid injection group is blue. After the first injection, the first shockwave, of course, cortisone works faster and the pain release is better on this side. After the second injection and second shockwave therapy, it's nearly the same. And then after 4 weeks follow-up with the 4 cortisone, I think 3 or 4 cortisone injections and 3 or 4 treatments with the shockwave, you see that the changes and that shockwave, the shockwave here goes down and down and down. It's the same after a 12-month. It's only decreasing and decreasing and decreasing on the shockwave side, and again increasing and coming back to the start on the steroid side. It's the same in the second diagram, the second score. Here you can see it even better, and now they change, and the shockwave group is getting better and better, and the cortisone injection group worse and worse. Now this leads to contraindications. I would like to start with the last one, because we had this theme at the last file. Cortisone injections, if they are made into especially a tendon or enthesiopathies, please wait for 6 weeks after the cortisone injection, because we all know that cortisone has got a horrible effect on some tissues. I had about 2 or 3 Achilles tendon ruptures after only one single cortisone injection. So please wait for about 6 weeks or longer. A few years ago we had 3 months, but 6 weeks at least. And then you can start with shockwaves, because if you start earlier, the problem is that they can say, okay, now it is ruptured after your shockwave, but we are sure that it is not the shockwave, but the cortisone injection destroyed the tissue, and then you come with your shockwave, and then everybody says, okay, it's loud, it's hard, there's a lot of pressure, so it must be the reason why the rupture occurred. Now we start from the beginning. The treatment over air-filled tissue, of course, you have to be careful because this is a contraindication, but you have to, it depends on what you do. For example, I had the example with my daughter with her lung. We only used, of course, radio. We used not much pressure, and over the lungs, it is very easy. If you start with a little pressure and then rise up, if the patient has no problem, then it is no problem for you and the treatment, because if there is a effect on the lung that is not good, they always start to cough. And at the first cough, I'm away from this point. You cannot destroy the tissue of the lung with only one cough. That's not possible. But you will see that you have an effect on the lung if you put it like I said on the post-corona or long COVID patients, or we even tested it now with people suffering from chronic bronchitis, and it seems to help them. But you have to talk to your patient, of course, because if there is any inconvenience, you have to stop it because of this contraindication here. And over the intestines, it's nearly the same. Of course, and sometimes there is a lot of air in it, and then you cannot put the pressure of the shock wave on it, because if the shock wave comes through the liquid part, means the tissue, and hits the air in the intestines, then you have the problem that it is, they say it is possible to destroy the tissue of the intestines. I'm not quite sure, but I wouldn't test it. That's why it is a contraindication. Then the treatment of torn tendons, which are injured over 50% of its width, it's difficult, because I would say, okay, every tendon that is ruptured more than 50% should be operated, of course, because the risk that it ruptures completely is very high. But we also had patients that wouldn't have an operation at all, and asked us if you could start with shockwave therapy, and then we explained that it could be that there could occur a rupture, not from the shockwave, but because the tendon is very small and very, very thin. And they said, it's okay, if there's a complete rupture, then I have to operate, but I don't want to be operated by a surgeon with this 30 or 40%. And then we started it. The results were, I think, very good, because the people got had less pain and were brought more life quality. And we had, after a time of 3 or 4 months, we saw that most of them had a very good scar and tissue healing, so that we had, in most of the cases, 50 or more than 50% of the width again. That was very, very good. But if you see it as a contraindication, you have to tell your patient that normally it is a contraindication. You have to send them to a surgeon. The treatment of pregnant women, also difficult, because of course you're not allowed to treat in any area that is near to the fetus. But if they are coming with, for example, the tunnel syndrome in the hand, or with a plantar fasciopathy. No, sorry, with a plantar fasciopathy, I'm getting dry. Then it is such a long way to the fetus, and you're not treating in the direction to so that you can reach anything of the stomach and of the body. So I would say it is possible. I had the same problem with a pregnant woman last week with tunnel syndrome on both sides, carpal tunnel syndrome, and plantar fasciopathy on both sides. She couldn't walk, she couldn't grab, and then we started. After I had to explain it to her, of course, that this is a contraindication, but she said she cannot go on like this, and she wants to start this. And then after the first treatment, she could walk properly, and she could go out and do like this. So it is always depending on what the situation is. But you have to have in mind, you have to talk a lot, and you have to have it signed that you explain that this is a contraindication. This is very important. The treatment of persons under 18 years, morbid Osgood-Schlatter disease is known as an exception because it is known as a real indication for all the young people under 18 years. And you can treat it without any problem. All the other things that you want to treat are really depending on the parents. If you explain it to the parents that this is not, it doesn't have to make them anxious, and there's no problem for the bone or the growth line on the bone, then there's no problem. Because if you can explain it them and show them and make a picture that the shock waves come in a way that are not hitting the growth line in the bone, then there's no problem to work with the children. But you always have to say it's a contraindication, have to explain it to the children and to the parents, and then have to have it signed. Okay, patients with blood coagulation disorders. This is difficult because in some cases you can set a hematoma. That's why you have to tell them that this is possible, and this is a contraindication, that you don't want to treat them if they want to have it treated. Then you can try it somewhere where it is not so important. If they are getting a hematoma, then please stop it and tell them that you can't treat them anymore. If they have had thrombosis, please do not work on them. Maybe when they are 10 years old and the thrombosis and there's no problem anymore, then it would be possible, but I would have this checked before I tell them that it's possible to treat. The treatment of patients with oral anticoagulants, it's the same. They can have bad hematomas, so you have to talk to them before and show them on a part where there's no problem if they get a hematoma, like the arm or something. And if nothing occurs and they absolutely want absolutely the treatment, then you can try it, but always the same contraindication. Tell them about it and let them have it signed. Tumors and local bacterial or viral infections. It's depending. Local bacterial infections, for example, we have the indication the diabetes foot with wounds. It's possible to work with them, but local bacteria and any other area at the body should not be treated. I think it's a bit difficult to say I can treat this one, but I cannot treat this one. You have to do all the other things. You have to give antibiotics, disinfection on the wound, and so on. But then you can work around the wound to get growth factors in it and to get a better wound healing, to get a better blood flow. I think this is possible, but it is on the contraindications list, and so you have to talk and to talk and to talk. Local tumors. We had some local tumors that we had to work on because of big lymph edemas around the tumor. That's the same. We talked to the patient. The patient said it doesn't matter. That I'm responsible for it my own. And then we started working with the lymph edema, which is great. You can reach a lot with big lymphedemas and give the people back a lot of her life quality. But if there's a tumor in the middle, we didn't have any bad influence on the tumors yet. We had a lot of them. We didn't have any bad influence, but it is a contraindication and they have to sign it. Okay, so these were the contraindications. To think about all this, I said I had again the picture of the abstract from my daughter's lung, really contraindicated. I think you can make up your mind yourself. And I end this webinar Year one with my sports philosophers, thinking about shockwaves. I love them. For example, Oliver Kahn, one of the most famous and well-known goalkeepers in the world, played for Bayern Munich, said X. We need X means that we have to be brave. And that's what I tell everybody who wants to learn shockwave therapy and wants to help people. Sometimes you really have to try it. Maybe it's off-label, or maybe it's not used so often, the shockwave therapy, for the indication you have there at the patient. It doesn't matter. Talk to the patient. If you are sure that you can help with the shockwave, talk to the patient. If the patient is with you and signs it, then you can try it. And I think in most of the cases, you will be very satisfied with the result. Bertie Vogts, one of the most famous players of the German national team years and years and decades ago, said reality is different from objectivity. This is very good to explain shockwave. As I said before, you will be satisfied with things you never thought about treating with a shockwave, and the reality we have during the treatment is really different to what you know now or before. Quality comes from agony. Felix Magath is known as one of the most famous football players in Germany 2 decades ago, but he's also a trainer, a manager of football clubs, and he was known for being very hard to his players. And this was the sentence he said. And means for me, shockwave could be a little bit painful, but it works, and the quality comes with the pain. This is the most important and the best one I could find for shockwaves. Pain is temporary, glory is forever. George Best, from a British football player, one of the most well-known and famous in the world. This is exactly what shockwave does. First pain, and then perfect painless time, much more life quality. So pain is temporary, glory is forever. And so I end this webinar at the moment before the discussion with Horst Rubisch, is also a well-known football player years ago in Germany in the highest league. And he said, I'll just say one word, thank you very much. So thanks for listening.
Thank you for this great presentation, Peter. That was very interesting. Thanks. And I'm just looking now at the Q&A section. We have a couple of questions. Andre has several questions. I think it was...
Hi, Andre.
Yes, I think he has a question concerning, that was the slides regarding the molecular and cellular mechanisms. He's asking C fibers signal for acute pain and A delta for non-pain. Capsaicin works only on C fibers.
Yeah, capsaicin works only on C fibers. That's a little bit different to the shockwave. Shockwave also works, maybe because of the mechanic effect, on A delta, and A delta works back on the C fibers. So it's not A delta that works, but A delta works a little bit back on the C fibers, and that's why it's called gate control, because the A delta is then the gate working back on the C fibers, and C fibers only for it is also acute pain, but over the time it gets a chronic pain, and C fibers are slower than A delta, and so we say it's for chronic pain or a slower pain.
Okay, thank you for the difference. Thank you. Second question from Andre. In early days, Miller uses placenta cells to stimulate healing.
I know what he means now.
Was that what you were looking for?
The placenta cell was one thing. I think he started it and then he crashed it very fast because, as I know, it didn't work. Now they're again working on that, but it didn't work when Müller tried it. Now it's growth factors from blood, but I don't know the animal they used. I'm not quite sure, but it's from blood.
Okay, thank you. And third question from André, what about the morbus fever? Also no with juvenile people? I think he refers to the slide about contraindications. What about the morbus fever?
Also no with juvenile people. No, I treat the morbus fever with in every age. The last one I had was 7 years old. So and the children really can't step on their foot. That's very, very impressive to see. They're really only coming up on one foot, the other in the they put it high so that they don't touch the ground. And if you treat them, and sometimes for month, and then you treat them 2 or 3 times, and it's gone. It's very, very impressive. And in every age, I had
2 or 3 sessions, it's gone.
Yeah, and the last I had was really a bad one with 13 months, no jogging, no football, nothing, and we had 4 treatments, and then it was gone.
Wow, impressive. Thank you.
Yeah.
Next question is from Nura Sikin. Can you differentiate between ESWT and cryotherapy in terms of effectiveness for pain relief, and pros and cons between both ESWT and cryotherapy? Do you use cryotherapy?
Yes, of course.
Mm-hmm.
I love it.
Yeah.
For example, as you can see here. Wait a second. Can you see this? The cryolite. This is hyperbaric CO2 coolness. This is great, I think, because you can put it on everything to numb pain, which doesn't work with shockwave, as I said, in the acute phase of, for example, acute tendinitis. If you put it on an acute tendinitis, you will not get a better or a less pain during the treatment. That's why we don't start with this. If you have a very acute tendinitis or acute pain, the cooling is better, of course. Because we are not working on this acute reasons of the pain. So I think cryo is much better in acute situations. And then after that, normally we need about 12 hours that we use the cooling, and not only the hyperbaric, which is very fast in 4 to 5 seconds. The tissue is about 4 to 0 degrees. This works very fast, but we also work with a kind of plaster, not a hard one, but there's a fluid on it that makes it very cool. Or you can put on ice, as you know it from everybody, in your fridge. Doesn't matter. The first 12 hours are very, very important. After, for example, distortion or something, then you put it on for 12 hours, and then. Or the laser is perfect. That's very, very impressive to see laser and cryo in this acute injuries. And then after about 12 hours, maybe 24, you can start with shockwave much earlier than we thought the years before. Most of the therapists normally waited 2 or 3 or 4 days. That's too long. Start after 12 or maybe 24 hours, but that's the longest time. And then you can start with shockwave, and then you get the hematoma away, the lymph edema goes away, the pain goes away, because after cooling it down for this time, you can see the effect of less pain with the shockwave again that you know from the tendinopathy. That works really good, and that's the difference.
Okay. And do you see any disadvantage to use cryotherapy, or would you recommend it?
Not at all. What we do is that we, in a lot of cases, we start with shockwave therapy because it's not acute, it's chronic. And after that, for example, for trigger points, it's perfect. After that, the patient, I know that there's for the next 12 or 24 hours, the patient will suffer from it's getting worse in the tissue because it works and works. And this working pain after the first, second, maybe the third treatment with shockwave, you can stop a little bit by using cryotherapy after the treatment. That's what we do after the first and second treatment. When they say, oh, last time I suffered from a lot of, I call it working pain of the tissue after your treatment, then I say, okay, this time we use the cryo afterwards. Or if it is, for example, if there are taut bands that are very hard, for example, in the neck, and they cannot move properly, and then you use the shockwave, and then it's perfect afterwards to cool a little bit down to have less of this pain afterwards. Because this pain is coming sometimes 10, 12 hours later in the evening or something, and they say, oh, what did he do to me with this treatment? And if you put the ice on it afterwards, then you don't have this effect so hard.
Okay, perfect. Thank you for sharing all this, all your experience about the use of cryotherapy. Thank you. We have a question from from one of our experts in Indonesia, Dr. Arif. Hi, Dr. Arif. So it's a long one. So
yeah, I try to read it.
It's a long one, but based on the animal study, shockwave could activate the osteoblasts, accelerate the remodeling, which could treat the non-union fractures. As you mentioned, that shockwave can break the bones easily. Based on those hypotheses above, could shockwave treat the osteoporosis patients? Should we be aware or cautious to treat the osteoporosis patients with shockwave? Should we know the severity of the osteoporosis and the risk of fracture based on the BMD or other markers? I had a case of geriatric patient with iliac crest fracture after treating with shockwave therapy by a doctor. I wasn't sure whether the patient was treated with radiofocused shockwave therapy, the patient treated with shockwave for low back pain. Wow, it's a long one.
Yeah, it's a long one. I'm wondering a little bit because I've never heard of any kind of fracture after shockwave. Never at all, and not over the world, because I discussed such cases with Professor Schmitz several times. There's nothing, and no one single case reported in the whole world. I think that you can break the bone. They did, I think, with animals, they did studies where they tried to break the bone. I'm not quite sure when it was. They tried to break the bone with incredible high pressure, 5 times higher than you can put the DuoClast or the PiezoClast. And I think with 5 times it was possible, but I think in one mouse, I think. I'm not quite sure. But this was the only one reported, but with 5 times higher than the highest setting that you can have on the DuoClast or the the PiezoClast and the DuoClast. So I cannot imagine how this should happen, because osteoporosis is, I think, in the next years it is a clear indication, and there are a lot of studies that aim to prove that this is one of the most, I think, for the future, one of the best therapies that you can have for osteoporosis. So it's really hard to say how this should have been possible. Yeah, I'm a little bit shocked.
Okay.
Because we treat a lot of people. We treat people with low back pain, with sacroiliitis, all this without any problem. About 30 to 40% of my patients are back pain patients, and we have absolutely no problem with them. So I don't know what the guy did wrong with this shockwave. I hope he didn't do it like this with the shockwave device. I don't know.
Yeah, we never know, but I hope not. So as shockwave therapy stimulates bone formation, so you would recommend it for osteoporosis, but if you have already a partial fracture, which is visible on an ultrasound, and that's actually
yes, you can use it for both. You can use it for.
Okay. I'm losing you, Peter. I think the network is going now, but yes, I'm losing you. Well, it can happen. Please wait a few minutes or a few moments and Peter, can you hear me? I think Peter is offline right now. So we know that shockwave therapy stimulates bone formation and can be very useful for treating this kind of indication such as osteoporosis. Peter, can you hear me?
Yes, can you hear me?
Yes, yes, we are back. So you were saying that in the case of a partial fracture, you would use shockwave.
Yes, of course. We do this also especially for professional sportsmen when they were operated because of a fracture. And we start the second day after the operation, if it's possible. So we use it because we know that the bone is healing much faster and much better if you use shockwave as soon as possible.
Okay, so that answers your question, Andre. We have a question from Dr. Cynthia, how we treat long COVID with ESWT or SWT. Thank you. So this is regarding the case report about your daughter.
We did a video to show how it works. If somebody wants, please leave me your email address. I'll send it to you. It's about 6 minutes. We didn't start the device so that you can understand what I'm telling. It's just on a dummy. It's a friend of mine where we show how we have to work on the lung. Because this is, for me, it's very important because I think it really works and it does so much good for people suffering from this long COVID. So please send me your email address. I'll send you the video, try it. Talk to the patient. If he's coughing, then go to another place, not there where he had to cough. You can, in my opinion, and the opinion of all of these guys in my network, you cannot break anything. You cannot do any harm to the lung, but you can help the people to breathe easier
and breathe better,
and bring them back to life. And that's really important because some of them really are suffering, cannot do their sport anymore, and so on. That's hard, really. So please send it to me, and then if I send you the video and you try it, please give me a short report how you did. Then we can discuss if anything was wrong. I would like to have this done more in the whole world.
Yeah. Do you think it would be possible to share this video, because it's very interesting and it's it's a current, I mean, it's from the current situation, it would be interesting for practitioners to know that, but I know it's an off-label indication, so I was just wondering.
Yeah, but for the people who want to see, try it. Wait, I'm not the specialist for the Zoom webinar, but I'm trying.
But I think it would be, well, if we can, well, share it and
wait a second, I think I have to go.
Or maybe we share it by in a link by emailing, and we share it to the community. I think it could be of a good interest for practitioners.
I know where I have it. Wait a second. I'm seeing. Christine, wait a second. So okay, I think this is it, right?
That will be the cherry on the pie for your presentation.
So wait, but it's in German. That's the problem. But you can see it. start it now and I try to get it
I
in.
think we could use it and have it translated in English. Or
Wait a
we
second.
could do it. But we
I
need,
think-
we need the authorization. Maybe we discuss it.
Can you see it?
Yes, well, I can see it, and I think people can see it.
I hope that everybody can see it. Wait a second, I put it in the middle. Oh, that was the wrong one. So, okay.
So, Herr Robert, nachdem leider durch die
I try to translate a little bit. First of all, I talk about the long COVID syndrome, of course.
Vor einem thorakal auftreten, haben wir eine Methode uns ausgedacht, das eben deutlich zu verbessern, dass die Atmung besser wird und auch diese
A little bit further and we start. Okay.
Im Bereich das genau erklären zu können, da müsste ich zu sehr schreien. Deswegen zeige ich es jetzt erstmal so.
And now I just explain why I don't start the device, because it's too loud and we cannot talk about it. We try to treat the muscles, the paravertebral muscles, because they are in most of the cases with these people, because they are trying to breathe hard or they are breathing hard, the muscles get hard, and we try to lose them a little bit, relax them. Same as with the shoulder bladder.
So we were talking about people suffering from symptoms of long COVID.
Yeah, COVID, and I had in the last weeks we had some chronic bronchitis cases, which we tried, and they worked the same way, and it worked really, really good. And this is one point that I want to explain. It's in high of the vertebra number 7 of the breast, of the thoracical vertebrae. It's number 7. It's a very important point in the Chinese medicine. I think everybody here in the audience will know that for the diaphragma, and this is very important to stimulate this point to get the diaphragma free. And then we go like this between the ribs. Yeah.
Looks like it's very gentle. It's
you don't have to put so much pressure on it. You can first work without any pressure. And we work on both sides. That's important, not only from behind, but also from the front. Here is the same problem with the intestines. I try to go away from the intestines, but you cannot really hit them if you work like this. You always have to remember that we only work on the surface of the lung, but it's not only the lung, it's also the diaphragma, and we go deep about 4.5 to 5 centimeters. That's enough to stimulate the diaphragma like this. And always tell your patient to breathe in deep during the treatment, because so much myoglosses are relaxing during the treatment that you can move it much better, your whole chest much better, and also the thoracical vertebrae.
Sollte der Patient, wichtig ist nur, dass der Patient während dem Atmen orientiert an dem, was man auf der linken Seite behandeln sollte, er versuchen stark nach links zu.
Yeah, that's what I said before. If you work on the left side, try to breathe into the left side as strong as you can, and on the right side the same. And another point is why we worked on the back very long at the paravertebral muscles. Under them you have the joints of the ribs and the paravertebral joints, and most of them are hardened or inflamed through the problem working with it for weeks, and so you have an inflammation in these joints, and you have to get this away, and there's the shockwave perfect for the treatment.
Auch die Frequenz ist auch noch was Besonderes in dem Bereich.
Aaron, there's one thing. Normally we work always with 20 or with a new device 25 hertz. At the lung, it's a little bit different. Some patients say that they tolerate 17, 18 or 19 hertz better than 25. I cannot tell you why. Maybe it's because of the frequency of the vibration, but then they say, okay, that's better than you had before. And so the lung is you have to talk to your patient. Is it good with 25 or 20? It depends on the device. Or is it better with 18 or 16? But I had no patient lower than 16, but maybe that they say it's better with a little bit less frequency. Okay.
You have a nice patient, a happy patient then.
This is Alexander Eppler's one of the most or the most famous shockwave therapists in Germany. Is a physiotherapy therapist. Perfect dummy.
So Andre had a question concerning this kind of treatment, and please, everyone, please have in mind that this is an off-label indication, and it works. We can see it works, but as it is an off-label indication, we don't include it in the DuoClast user manual.
Yes.
But Andre just mentioned you don't treat the lungs, but the intercostal muscles and the diaphragm and the paravertebral muscles, correct? There's no real risk for the lungs because of the penetration depth of our stability is approximately 3.5 centimeter.
Yeah, that's what I said before. I think Andre was writing while I was explaining. Exactly, he's absolutely right. I mean, Andre is nearly every time he asks a question, he's right with that what he says, because he knows a lot about a shockwave. So Andre, perfectly explained. You only touch the surface of the lung a little bit with the 5 centimeters depth, but the rest is, as you said, we're working on all around it.
Exactly, yeah. Exactly. So thank you for sharing this great video, and the patient looks very happy, so that's promising and positive. A last question from Xu, how to measure the energy density of shockwave when getting through the tissues in the body?
That's a good question. We should ask Professor Schmitz how they did it, because it is depending on the pressure. Depending on the device, special pressure is a special kind of energy flux density. So I don't know how much I go through how much energy I go through the tissue. I know the pressure, and I know how it works on the patient, on the muscles, on the tendons, and so on. And I get my feedback from the patient, but I cannot tell you every moment how much energy I put in there. But this would be a great.
I will keep this question and check with our with Christophe and.
Yeah, that would be great. I think.
And even internally with our maybe our engineers, just to check how to measure this, and that would be interesting for the community to know this. So I will get back to you with the answer to your question.
If Christoph answers that question, think about 10 minutes. A monologue of 10 minutes.
Definitely. Definitely. So I think we're done. We have a couple of other questions in the chat. Yes, we have just the last question. After doing shockwave therapy, how long the gap that we should for doing shockwave therapy?
The first question in the chat was about, let me see, could you please explain how to choose frequency for each symptom? That's very important, because I didn't explain it too much. It doesn't matter on the symptom. Years and years before, we started always with 6 hertz, and then we went up to 12 or 14 hertz with the DuoClast, and only, and this is important, only with the DuoClast. All the other competitors are different completely. You saw that at the diagram I've shown you. Only with the DuoClast, it doesn't matter. That's very important. It doesn't matter how many hertz you take. We always take 20 hertz or 25 with the new one, because this is less painful for the patient. Very important. You can try this. Try it on your hand with 6 hertz, for example, and then put the same pressures, keep it on your hand and put the frequency to 20. And then you say, oh, was very painful before with 6 hertz. And then I don't feel anything painful with 20 hertz. It doesn't matter. Take 20 hertz every time. You have no time to lose. So your treatment gets faster. The pain is less for the patient. There's no reason. I know they used it like a how you say, like a list. You have to do this for this indication. You have to put 6 hertz for this 9 hertz. Nonsense, really. Try it. You can try it on your own. You can try it on your friends. Put the highest frequency you have with this device. You can do it, and then save time and be less painful for your patient. So the second one was, after doing shockwave therapy, how long the gap that we should for doing shockwave therapy again? Good question. Normally we have about 1 week from the first to the second and the second to the third. After 4 or 5 treatments, normally it's much better for the patient. And we say, okay, if it's chronic, now we have a gap of 3 or 4 weeks. And if this works very good in the meantime, then we have 6 weeks to 8 weeks. For example, with the polyarthritis hands, we start with the first and the second treatment normally in 1 week. Then the third one after 7 to 10 days. And after 4 treatments, they say, okay, that's really good now. I can do a lot. How long can we have a break? And we do a break of 3 or 4 weeks. Then the patient comes and says, nah, it's okay. Or, oh, after 2 weeks, it was terrible. Then we go back to 2 weeks. If 4 weeks was okay, then we do a little bit more. And then after 6 weeks, and now we are between 6 and 8 weeks for this chronic polyarthritis patients. And I think this is great, coming to our office every 6 or 8 weeks for 10 to 15 minutes treatment, and have your fingers like this and not like this. This is one example, but it's in most of the cases, it's 1 week, and then we go wider gaps. If you start with muscle, for example, or tendons with a professional football player or professional sportsman, then you can do it every day. Doesn't matter. Because the time between 24 hours between one to another treatment is enough for the muscle to use the growth factors and work with them and to recover, and then you put the next energy on it. So you can do it every day if you want, and you will see it works very, very good, especially when they have a big hematoma, for example, in their muscle, then you get it out very fast.
Okay, perfect. Thank you for this full answer.
These are important questions. That's really good questions, important questions, and I think everybody has to understand that.
Exactly. No question for Peter. The remark 6 hertz minimal to achieve cavitation. That's a question from Monday.
Where is it?
It's in the Q&A. No question for Peter, but just a remark about 6 hertz minimal to achieve cavitation.
Yeah, he's the next professor. Andre, I love you.
Exactly. So thank you, everyone. We're coming to the end of our webinar. That was very interesting. And so please stay tuned, because we will have our two practical sessions next month, end of October. So stay tuned. You will receive an emailing with those dates and the registration link to register for this event. Thank you again, Peter. That was great. And for those who are registered already, or for those who are not yet, we will have a GDT webinar tomorrow, so guided DuoClast therapy webinar. So if you are not registered and interested, please go to the website and register online. We'll be happy to have you online with us. So thank you again, Peter. And so see you tomorrow for those who will be there, and see you next time online for the others. Thank you.
For the pleasure. All the best.
Thank you.
for all of
Bye-bye.
you.
Bye-bye.
Bye.